Good morning, everyone, and welcome from Mount Sinai Hospital for a Thanksgiving special live peripheral case broadcast. Today, November 25th, I welcome you, Vishal Kapoor, with my partner, Sardar Farhan.
Hello.
And we are here for another exciting case from Dr. Krishnan and his team. Before we go into the lab, just wanted to give you the details of the website, ccclivecases.org. Please log into the website. You can go to the peripheral section, see our archive cases. You can see this case again by the end of the week. Leave us questions, comments, concerns. We'll be more than happy to get back to you. So without further ado, good morning, PK.
Hi, good morning, everyone. I want to thank everybody for tuning in today. Obviously, it's right before Thanksgiving. Can I have the long Terumo, please? Or actually, you can give me the super core. So we have a very exciting case today. We're just getting things ready from the radial, and basically, I want to welcome you to the cardiac cath lab at Sinai, and I want to introduce our team. To my right is Dr. Karthik Guja, who's our Associate Director of Endovascular Services here at Sinai and one of the long-term faculty here. To his right is Dr. Raman Sharma, our current fellow in endovascular, who will be joining us as faculty next year, looks like. Then to behind him is Ray Lascano, our endovascular nurse practitioner. And then we have Elizabeth, our endovascular nurse, Marichu, who woke up today for the case. And we also have Damien Cabrera, who's always here for the case with us. So what we're doing is a very difficult case because of access issues. And before we get started, I'm going to go ahead and ask Dr. Sharma to present the case. I need that wire back.
Of course.
Go ahead, Roman. Roadmap again? No.
All right. Good morning, everyone, and happy early Thanksgiving. Today we're going to be doing the following transradial intervention of iliac disease for chronic limb ischemia. Next slide, please.
Okay, now give me the wire again.
So this is a 54-year-old female smoker with known PAD. She has a fem-pop bypass on the right-hand side. And she also has a history of unsuccessful PTA of a left SFA CTO back in 2019, October. And she presents this time for a non-healing left foot first toe ulcer for the past 2 months with associated ischemic rest pain, Rutherford grade 3, category 4. She also recently presented in the middle of October of this year with an end STEMI. She found to also have a right CFA lesion that is immediately proximal to the fem-pop bypass on the right side with a distally patent fem-pop bypass and bilateral external iliac stenosis. She has a significant past medical history of insulin-dependent diabetes, hyperlipidemia, hypertension, and ischemic cardiomyopathy with the EF of 40%. She's currently on all the goal-directed medical therapy with aspirin, insulin, Lipitor, Imdur, beta blocker, and then also some psychiatric medications. Next slide, please. This is the ulcer that she has had for a while. Does not look very good. It's been actually progressing since. This is the most recent picture. The picture from when she first presented during the end STEMI is significantly less severe. And we see that the lesion is involving almost entirely just the first toe. Next slide. So here we have the initial angiograms. We have some more pictures we'll be able to show you today. But we see here on the left image the iliac lesion. We see right at about maybe 12 o'clock in the middle of the screen, we see the lesion of the right external iliac. And we can faintly see, actually in this picture we can't actually see the CFA lesion on the right side. The left side we see the still frame of the left external iliac lesion, quite significant. Next slide. Here we can see this here, right by the femoral head, we see the lesion and the CFA, right proximal to the patent fem-pop bypass. And we see the 3-vessel runoff to the foot. Yeah. Two. And some nice ankle jewelry. Next slide. And here we have the angiogram of the left. This is the SFA CTO that was failed back in October of 2019. We see the proximal almost no cap, but we see a little sliver in our angiograms today. We'll be able to show you this proximal stump a little bit better. And to the right-hand side, we see the distal reconstitution of a moderate to severely diseased SFA with tibia vessels with a quite healthy appearing posterior tibial that goes to the foot in case we have to approach this from a pedal approach. Next slide. Now, after the end-stemming that was done in October, the right external iliac, which was seen at the end-stemming, was treated with a Absolute Pro 10040 stent. And this is the final picture of the right-hand side, which we can also appreciate on our angiograms today. It appears quite patent and well expanded. Next slide. I think for now, maybe would be a good point to pause.
We'll just discuss a little bit. So here we have a guy, a young lady who has obviously severe peripheral arterial disease. What's our ACT, guys? Good. So who's got severe peripheral arterial disease, cardiac disease, who basically presents with a Rutherford 5 presentation of the left lower extremity. So she had this complex iliac, which wasn't done, as Dr. Sharma said. So we fixed the right iliac. But the issue became in terms of fixing the left iliac because of the right access point. So I want to show you what we saw, because we got access without ultrasound last time, and while we fixed the right. And we were able to do the right iliac stent from the right groin, but at the time of intervention, we noticed that there was a tight stenosis proximal to the graft. So you can see here with the pigtail and with the Terumo 119 or 118 sheath, you can see that the common iliac on the right side is fine, but however, there's a significant stenosis at the inflow. Ultrasound done in Pennsylvania showed that this inflow stenosis had a peak systolic velocity of 324. Obviously needs to be fixed because of the graft that's feeding the right leg. On the left side, you can clearly see here you've got a difficult. You've got an SFA lesion. Excuse me, external iliac and a common iliac lesion. But what's really important to see is that the patient does not have any robust internal iliacs. She has significant disease of the bilateral internal iliacs, and therefore the compromised flow into the profunda femoris on the left side is the reason why she's having so much pain. So one of our ideas today is to go ahead, get radial access to fix both, because obviously we could have gotten left access, but the idea would be if we don't have enough flow into the BTK vessels, we wanted to either do a direct SFA access to go ahead and fix the left SFA, and or pedal access to fix the left SFA after we use radial access to fix both the right common femoral and the left external iliac / common iliac. Since we don't have a internal iliac, I'm just going to call it left common iliac external iliac. So at this stage, just to tell you for the sake of time, it's 8:05. We've got a lot to do today. I'm going to just turn it over to you. Karthik and I have decided to go with a drug-coated balloon, which I know is off-label, but she has very, very small vessels. We're going with a 6.0 impact into the right common femoral and into the right, common femoral / external iliac. What we have is a 119 centimeters sheath, right? Yeah. Terumo up and over the arch. We've got a pulse ox on the same arm of concern that shows it's at a 99 to 100%. Patient has been sedated magically by Liz and Merichu, and now we're going to go ahead and do this. The question is always going to be length, and maybe you guys can talk about this approach, how you guys would have done it different, so on and so forth.
So Sardar, so what do you think? I mean, so his strategy of approaching radial versus alternate strategies of femoral access, maybe pedal access, fixing, staging. So what is your thought process on this?
I think the choosing the left radial access is actually a very good and smart decision, because as we saw by the presentation of Dr. Sharma, that both common femoral arteries are heavily diseased, and obtaining access there might be a challenge and might end up in aborting the case. Another alternative access is the pedal access or the direct distal SFA access. That would be also feasible, but to start with is always the transradial better in this case, so that we can actually do roadmaps for the direct.
Put me on coronary, guys.
Yeah, so, I think that's a good. Yeah.
So one thing, Vishal, just to let you know what's happening, the drug-coated balloon. Sorry, put me on coronary. The drug-coated balloon is not reaching. So what we're going to do is we're going to go ahead and advance the sheath in further. I wanted to avoid going into that stent, but we're going to have to do it. So I've got the dilator in. I need a wet one here, and Dr. Guja has been kind enough to give us some nitroglycerin to the arm. Mag up, guys.
So so one of the important things to consider, especially to do transradial, is the sheath really has to go very close in. You cannot have a sheath extending out of the vessel. Otherwise, none of those devices will reach. Because most of your devices, your balloons are 150 shaft,
that's good.
And the sheath is 119. So you have to be cognizant of that extra 30 millimeters, which might be hanging outside the arm, which might inhibit from you transmitting any of your devices down. So in all of these cases, if the lesion is more distal, it actually works in favor of you if you're doing transradial. If the lesion is more proximal, where you have to get the sheath out, it just becomes harder for you to put the stuff in. So the sheath has to be really close to the lesion in all these cases because of the restricted length we have. I mean, we do have some balloons like the Metacross balloon, which comes with this, which is longer shafts, which is like 190 shafts. Will get you there. But then if you want to use your standard protocol, let's say if it's CFA and atherectomy or a DCB, which comes in standard shaft lengths and not extended shaft lengths, it could give you a little bit of trouble. So I think he's right.
No, let's do 60.
And I guess one more important point to add here is, remember, there's a bypass graft coming out from the right side as well. So if you get a right CFA stick access and there is, God forbid, there's a complication, now you're compromising two legs and making them two critical legs instead of one leg. So you have to know your bailout strategy as well.
That's a great point, because I got to tell you, that's why we decided to go with the drug-coated balloon here, because obviously we don't want to have any sort of issues with a stenting of this particular area. So now we're coming out of the sheath, hopefully with enough length, which we just barely do. Now what I want to do is I want to go to the other view. I want to go to the shot that we took. Scene minus, please. Scene minus. No, you can't inject. Yep. Save that for me on the side, Roman. And you can see it's right around 30, so we need to be a little bit below, maybe 30, or maybe the dot at 29 or whatever it is. So let me see now. Show me show me the same view I need. There it is, right there. So we maybe need to go a little bit further in. So
but you can inject a little bit. Of course, the dye is going to squirt out, but it's a 6 French fit. The balloon, you can still be able to see it. We'll still be able to see it.
A little bit of dye. No, we're not able to see it. So I think we need to go a little bit further in.
No, I think that looks perfect. You're right just above the takeoff of the graft. Because it's right below that 30 mark where your graft took off.
Yeah, but it looks like we might have to go a little bit in.
No, we have to go a little bit in.
Yeah, I agree.
The clip is right there.
You see the clip as well, right?
Yeah.
So you have to go a little bit in.
Yeah. Okay.
So you're pushing the entire system.
Yeah, I think that's good right there. Let's go up here.
That's more like it.
So this is a 6.0 balloon?
Yeah. And this is going to be at 8 atmospheres.
Is there any role of atherectomy right here?
No, I don't think so.
For a CFA?
I don't think so. Let's do
some nitro.
Let's do a
nitro.
What is it called? A cuff pressure, guys, for me. So what we're doing is we're just going to leave a DCB up for 3 minutes. Timer, please.
With this needle.
A DCB up for 3 minutes. You know, this is the challenge with these kind of cases. You have a very difficult lesion. You want to avoid going into the graft as much as you can. And it, hopefully we're in a position here where we're covering it. Looks like we may be covering it. We may just be short of it, but we really can't go any further in.
You can.
No, there's nothing really you can do.
You can hub it.
No.
Done. You can hub
No, that's it.
Well, you can, if you want, you can track it. Well, the sheath is next to the balloon. Otherwise, once the balloon comes out, you can actually track it over it, push it down a little bit more to give you a little bit of patency. Right
well, she's having a lot of pain because obviously now it's a small radial. She's spasming. I want to avoid manipulation as much as I can, of this radial while we're doing this. And these are some of the challenges of doing R2P. I mean, there's a lot of push towards doing R2P, but I really believe that, as good as R2P is, I think that the challenges for these kind of complex lesions remain. I think if you have a vanilla iliac, focal lesion, the Misago stents by Terumo are phenomenal. But in this kind of lesion where you're going to need some drug-coated therapy, I think this is the issue. When we walk it out, we can give some. Where are we going to give nitro?
Yeah, I think that's a very important point, especially with nowadays people talking about these alternate accesses like radial and pedals. We underestimate the degree of access site issues, such mostly spasms in these cases, and we really have to be cognizant of those facts because that can restrict your success of the procedure itself. So I think that's one of the important things to think, especially in the radial and pedal accesses.
So I'm just hopeful, Vishal, that I'm able to get somewhat of a lumen here. If I'm able to get a good lumen and I'm able to get, even if I have to use a regular non-coated balloon distally at that site, I will do that. But I think that here at this stage, if I'm able to get a reasonable lumen without any loss of any dissections, then I'm going to be quite happy. The other thing also is Terumo hasn't come out with a 6-7 slender as of yet. So when they do, I think that'll help us use some of the larger DCBs available in the market, like the 7.0 Impact, which may help. I believe the Bard 6.0 Impact still goes through a 6 French sheath. 7.0 Impact still goes through a 6 French sheath. But we felt that the Lutonics, between the Lutonics and the Impact, in this particular case, we felt the Impact would be better suited for this particular lady, so we decided to go with that.
Yeah,
so
right. You have an alternative using Lutonics, which goes through a 5 French sheath as well. So the higher caliber, if you really have to go 7.0, a Lutonics can get there. I know you have. There is some issues with the data and patency and all the stuff, but purely on technical basis, Lutonics does go through a 5 French as well.
It's not good. Yeah, it's not going to go unless you push the whole system in.
Yeah, you have to push the whole system in. That's the only way it'll go.
The car thing is just pushing the whole system in a little bit and just getting a final balloon. Angioplasty of the distal area. But again, I think we were able to get the whole thing. So we're just going to do a little short distal ballooning here.
Yeah. I think Raman is saving on the dye today, Ken. But
yeah, it's okay. I agree. Raman is very good with dye. Down. So now that we stored that, we're going to walk this out. We're going to take a DSA picture. I'm just going to fix the sheath. So as Dr. Guja comes out, things are going to be okay. Once he comes out, we're going to take a DSA shot here. And once the DSA shot is done, we're going to take our concentration to the left iliac, which is going to be done completely with Terumo's equipment, which I think, again, we don't need drug-coated therapy in that area because of the fact that it's an iliac, and I think that the patencies with iliacs are phenomenal. Our pressure is severely damped here.
That's because it's right in the lesion. So
yeah, right at the lesion with the inflow. So I mean,
give me a little pullback. A syringe. So again, for everybody at home, always be careful with sheets and everything. Make sure there's no clotting. There's always a chance with these sheets when you're 1-to-1 that there's a clot. So I'm just going to walk this back slightly here.
And I think one of the more important points with the R2P sheet is very hydrophilic, so it moves a lot, and that can also cause spasms. So you just have to be cognizant of the fact that the sheet is not moving a lot.
Sorry, my love.
We underestimate the movement of the R2P sheet.
Little dye? We might have to use another balloon here, a little dye. Yeah, it's pretty moderate there. So I'm going to go ahead and take a DSA here. Ready?
1 second. Yeah.
Ready?
Okay.
It's filling.
Oh, 1 second.
You guys gave her some Lasix?
Okay.
I think we need to do that. The distal looks good, but around 25, you have a small lesion. I'm happy with the distal. Distal looks really good. I'm just happy around 25 where there was a little bit of thing. So I think while we're in there, we'll just put another DCB at that level.
Oh, okay. That's okay.
So give me another short 6060. So we're going to put another DCB here, or we can actually put a Misago at this level. You want to just put a Misago?
No.
Why? It's external iliac.
No, the reason is because the
femoral is very low. I think this is external iliac lesion. What do you think, Vishal? And I think we should just put a Misago.
Yeah, if you really go by the book, it's an external iliac where the DCB usage is still considered, I would say, borderline. So if you go with a regular PTA, I think it should.
Let's just do a Misago. What size Misago do you have?
I'll probably use a 7.0.
You have 8.0? 80, you have 8060, you have nothing shorter?
Yeah, 8040.
60 is all you have?
Go for 8060 if you want.
All right.
End at the right femoral.
Well, no, 60 is going to be too long. And what's the length of your Misago?
No,
200 length.
It's a 190, 200, yeah.
So the only question is, what about our Abbott stents? What length are they?
135, it'll go.
Abbott 135. So give me a 10-0-30 Abbott self-expanding stent. 10-0-20, 10-0-30.
Absolute Pro.
10-0?
So we're going to go
you want
with
10-0 or? PK, she's female. You want 10-0? Remember, it's a magnified view.
Okay. Well,
9-0
is fine. 9-0 is fine. 9-0-30 is fine. Again, you know, for those at home, this is all semantics. I got to be honest with you. There's absolutely no difference, in my opinion, between a 9 and a 10-0 in this particular lesion. You know, I remember our old friend, Dr. Sri Iyer, had an algorithm where he would put 10-0s in all the iliacs because he felt that there was no reason to undersize. So we'll go with a 10-0. We'll go with a 9-0. I need a 30. Give me a 10-30. So we're going to put a 10-30.
Yeah, I mean, it's a self-expanding stent, so you're right. I mean,
you want to dilate
We'll dilate after.
Yeah,
we're going to do a 10-0-30.
Stent, so you should be able to get a 10-0-30, and then you should be fine.
You want 7-0-20 or 8-20?
So the Misagos, I believe, only come in up to an 8, right? Up to an 8, and the lengthwise till
200.
I mean stent lengthwise. 40 to 100. You don't have a 40. You don't have a 40 here, right? So unfortunately, in our lab, we don't have a 40, but Terumo does have, just for everybody at home, from a 40 to 100. So obviously, for your practices, you should definitely get that 40, and we will definitely get that in here. But luckily, in the other side, we're going to be able to use their stent. We're going to go with a 8-0 longer stent to cover both lesions, and then take a picture. So right now, we're going to go ahead and place this. I guess the question Dr. Guja asked is a valid question. Why am I not balloon dilating? You want to do this on the roadmap, yes? Roadmap?
Yeah, we just...
Why am I not balloon dilating? What is your feeling, Vishal, about balloon dilatation versus stenting and then ballooning?
Yeah, well, I usually like to pre-dill my lesions before I deploy the stent. It's a self-expanding stent, so, you know, the apposition, I mean, the expansion is better if there's a pre-dill lesion. But if you suspect it's a soft lesion, we haven't really pre-dilled that part, so I would have probably pre-dilled with it and then dilled a self-expanding. But again, in this case, it doesn't look that heavily calcified, so I'm assuming after stent deployment, you'll be able to get your appropriate sizing with the balloon itself.
Just a little bit.
No, I think it's very good. I'm like it. Let's deploy it right here.
That's good.
Yeah, don't let it go forward. I like it. I want to keep it away from the common iliac and the iliac brim. So Karthik is just going to deploy it. Karthik wanted me to use a smaller one, which makes sense, but I think I'm going to go with a larger one here because there's going to be a size mismatch.
7-0-20 balloon.
7-0-20 balloon, guys. Completely agree. So we're going to walk this out quickly. So now we've gotten drug distally, we've got this part proximally, and now we're going to pull back and concentrate on the other side. And I'm going to need a Terumo wire as well, one of their 018 long wires, which are phenomenal. They have an 018 J-tip wire, and they also have a 035 J-tip wire, and they also have an 035 stiff to help us cross these lesions. So now we're going to go ahead and we're going to balloon this. So hopefully, you know, with this, I mean, I guess the question would be in terms of, you know, doing this from the radial side, Vishal. I mean, how often do you use radial in your particular practice? What are your thoughts on which patients are the best? Actually, let me ask Karthik, because Karthik does a tremendous number of cases as well. Karthik, what is your algorithm for going radial?
I mean, after the R2P came in, I think it changed the face of radials from for peripheral.
Liz, what's going on?
Yashit.
She's going the stent. Watch your sheet.
She's okay. Just watch your sheet back.
Watch your sheet back. We can pull it back.
No, I know, buddy. I know. I am pulling it back. It just went in on its own.
Yeah, it's because it's just straightening
it's
the
very
thing with the balloon.
Yeah. Okay, go. Okay, she's going into a little bit of spasm in the arm.
So I have a question from one of the viewers, and they're like, so you're assuming that the external iliac is at least 8 or even 9, maybe 10, worst case.
Yeah, I know.
And you're still using a 7 balloon. So how does it actually help you with the opening of a stent? You've deployed a 10 stent in a 8 or a 9 vessel and using a 7 balloon. So that's a question I have.
Well, all I want to do is go ahead and get the stent to start expanding. And once the stent starts expanding, and I want to tack up everything against the wall, unless I'm doing an IVUS, I'm never really going to know what the level of the stent is. So to me, I see there's a size mismatch proximally to distally, and so that's why I went with a larger stent, so I can now profile the stent. See that now that went more to profile. So therefore, if you look at this, Karthik wants me to go a little distal, which makes sense. So I'm going to go a little bit distal and get the distal edge so it flares out as well. Yeah. And then so this way we have full expansion of this particular stent at this level. Okay, down. So to me, Vishal, this is going to expand to the lesion that we needed to expand to.
Right. I mean, that's the advantage of using a self-expanding stent. It actually keeps expanding for the next 24 hours. So you will have an expansion or appropriate sizing of the stent based on the vessel size itself. So that's a good advantage in these cases. But I mean, one important point to consider is if you had to use a covered stent, then we have restricted options because you have a 6 French R2P sheath in there.
I know, but we have a VBX, so
right.
The VBX.
So that's why I was just bringing up the point.
Yes,
that you have to have these alternate strategies available in your lab.
Good.
Yeah, but the VBX also, you can take the 6 French 6.0 VBX through it, not a 7 or 8.
You can take a 7 or 27, right? The short VBX through it.
Yeah, you can.
As long as you have a perf, you can handle it.
I'm very happy with that. So we're done here. We'll do a runoff later. Now we're going to come up, and now we're going to go after the other iliac. So I'm going to pull on this again. So Karthik, can you talk a little bit about what you've been doing in terms of giving, what is it called, vasodilator?
So, I mean, the only choice we have here is to give subcutaneous nitroglycerin. So I've been giving subcutaneous nitro just to relieve some spasm. So she's a female, and a short female, so I'm assuming she's going to have small radials. So that's probably the reason why she has a spasm. And again, she has some tortuosity. She's older on the age. She has a lot of, she has some peripheral atherosclerosis also. Together, everything is causing spasm.
So what I'm doing now, as Dr. Guja was saying, and I think this is important for everybody at home, don't just pull back the sheath. Use the dilator, go negative on the hand, and just come back as a system very, very slowly, okay, so she doesn't have much pain. So hopefully at this stage, we came back a little bit more. I need to come back. Sorry, my love. So we're right there. Okay, no more. Okay.
I agree with Karthik. I think it's a very important point to use vasodilators as aggressively as possible. Because the spasm mainly happens at the radial level. Once you're in the brachial level, the vessel size increases, so your chance of spasm is less. So what I would do is you take a nitro paste on a 4x4 gauze, wrap it on it, and you can actually paste it on your forearm, and that gives you that vasodilatory effect as well, especially when you're having a lot of spasm. It really helps you. That's what I do in my radial R2P cases as well, just to give local paste nitro with gauze.
Why don't we do some nitro paste? I think that's a brilliant idea by Dr. Kapoor. And let's do that. Dr. Sardar, is any data associated with sublingual, nitro paste causing vasodilation? Because listen, we have. No, it's very important because why? Because there must be data because remember that we use nitro paste in the coronaries, right? I mean for angina. So the idea would be is that I think you're extrapolating, but we don't have any, and that would be like a nice simple study to do to look at vasodilation in the radial artery using the nitro paste.
Came out.
I don't know if you guys can look on PubMed and see if there's anything like that. That'd be kind of cool to do because at least because this is a real problem. I think our Terumo folks will agree with that because there's one of the things with R2P is that it's a great concept. No, I don't want to wire with this. Give me the Terumo wire now. The R2P is a great concept, but it's associated with complications of spasm and sometimes severe spasm.
No, Jay.
Give me some dye.
Yes, I think that's a very good point. Yeah. And but it definitely helps us anecdotally. You can get all the.
Well, my friend, I mean, we do it in the heart, right? I mean, remember we've used nitro paste for years, so 100%. It does work. Even though there's no hard data associated with it, at least in the radial. Can you bring a roadmap, guys? So I think that's a brilliant idea. Liz, can we do that, please? Thank you.
There is on clinicaltrial.gov there is topical nitroglycerin treatment for radial artery spasm prevention. ENT RASP trial, but it's ongoing. Last update was by October 27, 2020. Phase 4 trial.
Phase 4 trial. You have tropical, which is great.
Topical nitroglycerin versus topical lidocaine.
I don't know. Let me ask Dr. Sharma Raman here. In our busy coronary practice, I know Dr. Barman is our radial director. Does he do that, Raman?
So not necessarily the topical gel. I mean, the concept is identical, really. The nitroglycerin will absorb even transcutaneously, even if you just use the purely soluble form, even without the gel. But subcutaneous injections, as Dr. Goodrow was doing, or a topical gel,
take it. No, I don't want to take it because they dissected it.
Gabor mentioned, all will result in some degree of vasodilatation. Now, the other important thing is that it's only temporary.
It's right here.
It's not going to be something. It's not going to be a complete resolution, but if you have some temporary, some temporary spasm that's just just kind of creating some difficulty advancing a sheath, or if you have to, in the coronary cases, or even in our peripheral cases, if you have to use a 6-7 slender, if you have to get these bigger devices in, it will provide some degree of help to kind of prevent further pain for the patient, and also just
so doesn't matter
technical
anything.
success.
6 or 60.
Might need an 014 wire.
Because you're using a 018 Terumo Gold?
No, we're using a 018 Terumo glide wire that's very poor torqueability because of the tortuosity. Unfortunately, this case was attempted at an outside hospital with dissections, so I'm a little concerned now because it's just not moving as smoothly as I would like. So I would like a Terumo Gold wire here.
Yeah, we can again.
And then we'll decide.
Gold.
Terumo Gold 018.
So yeah,
Terumo Gold, it's a great wire to go through these lesions.
So they tried an up and over technique with the outside hospital,
baby gels,
and they got into a dissection plane in the iliac from up and over. So we're coming from the arm. I'm a little concerned. We were able to navigate the first part very easily with the Terumo 035, which is a great torqueable wire. But I think in this area, it seems to be a more complex plane of dissection. And I think that's very important for everybody at home to get a hold of old films, look at what was done. I mean, things happen, just to document everything and take care of it. Liz, can you check our pulse ox? I don't know why we're losing it now. I mean, we had it before. I know. I just want to make sure that I'm going to wait for Liz not to radiate her while she's checking the pulse ox.
Torquer. Go through more of the slides in the meantime.
I think it's just about choosing the
Thank you, Lizzie.
choosing the right wire and getting through air. Iliacs, usually hydrophilic wires work great. This 018 Terumo Gold is an excellent wire. Finds microchannels, especially also in re-entry planes, which can actually help you transverse through and attain your final
there
results.
So got through. Okay.
Yeah.
It went through nicely. Yep. Okay.
That's
very
a
good.
support catheter.
So now I'm going to just check my position. I got blood back. Again, don't be fooled. In dissection planes, you can get blood back. I just want to check my position here with a picture. DSA, gentlemen.
Yep. We're on.
Actually, let me go the contralateral view because of our radial arm. Okay. So I'm just going to inject through the catheter just to make sure. Okay, very
Beautiful.
good. So now we're going to use a Terumo J wire. J is that soft or stiff? The J.
Soft.
Stiff, which is great.
It is good for.
So which is excellent for support, and we're going to be very protective as we work through these lesions. Again, this equipment, I mean, your local Terumo rep will have it. If not, you can call Justin on his cell. I'll share everything with you guys. I think the reasonable part is trying to get the equipment in. And I know it's difficult because in the sense that how many things can you have on the shelf, right? But I think it's good to have some of these sheets and some of these wires on the shelf for these type of cases where you kind of have no option from any other way. But what's also important to remember is that these wires are phenomenal wires. I mean, they work really, really well, incredibly torqueable, and obviously the lengths are very advantageous. Sometimes if you're doing from the pedal, so on and so forth, even to cross a difficult SFA snare and work from above, you can use the 035 Terumo wires to be able to help. So again, we're going in with the wire into this R2P sheath and through the extension.
Get the cheater.
Can you just put me on? No, you don't have to put me on coronary. So one of the big jokes here is that I can't see anything. So Sriya and Raman always complain. It's always 15 frames per second.
You don't need a knock.
You know.
It's a J. 1 second. Put me on. Let me put you on
Yeah,
coronary.
now you have to
can't
put me on
see.
coronary because I really can't see.
I know.
Okay. Oh, MAGA for me? There's something going on.
Yeah, something
Yep,
happening.
there's
there.
something going on.
Okay. It's okay.
See, there's a little diastasis there, guys. Okay, give me a torque
There's
right
a
here.
lesion right there just at the tip of the profunda as well. So,
I don't know. Show me C minus.
You're probably stopping the flow, right? So it's also to the.
There's
yeah,
good
the
flow there.
outflow.
But you see that double lumen there distally?
Right.
So give me a torquer here. I don't think you can torque this. It's got a J tip though.
I think it's a J tip. I would not probably be excited to.
No, see, it's going somewhere where we shouldn't. See?
There's a degree of calcification right there.
All right, give me a
018.
018
You can
thermal
take back
gold
your
again.
wire.
Why don't you go back in with the?
Yeah, you can do it.
Around
Actually,
the forearm.
Karthik's right. We're probably totally occluding flow, but I need to get this distal.
But remember,
Give me
there's a tight lesion proximally, so the inflow is already
Give me a
obstructive, and you're
roadmap.
probably against the lesion, so that's why there's no flow going down. So nothing is really clearing.
And there's no what is it called? There's no internal iliac.
Right. So I think that's where the important point is to make sure the sheets are flushed regularly, because this there's calcification
That
right
is
now.
probably stopping you from going.
Agreed.
Yeah.
Actually, give me a regular Terumo here. Terumo, a regular.
Go with this.
No, okay.
Go with this.
So you can
Karthik
see
wants
there's
to-
a lesion at 25 and also a lesion around 30. And with that eccentric
Then change it to a
calcification, it's
baby
probably
J. Go
stopping you,
down
especially
there.
using a
Change it to
J
baby
wire.
J.
Right, and now the
018
question is whether we're going to end up using a DCB or a regular balloon at this level,
You
because
can't use
it
a
is
PCB
quite,
because your sheet is up in the.
right. I know, and we're going to have to go through fresh stents. So there's again a lot of challenges
You can take
with
the
these
balloon.
cases, and whether we send her for an endo.
Watch your wire.
Let go. I can see it. There it is.
There, your wire
Okay,
comes
torquer.
right there.
I just want to put a torquer on it so I don't get into a plane.
Is your
So it's always good to have Karthik's young eyes. Not only is he good looking, he can see very well.
Ah.
You know, it's unfair, Vishal. You know, the young people have all the advantages. You know, Raman got all the hair and the hair monopoly. You know,
So you're telling me I'm old?
No, listen, Sardar got all the height. And you got all the brains, and I don't know what I was left with. You know?
And you became the director for endovascular. So you're all three combined. That's what PK is trying to imply, that he's smart, handsome, intelligent, and he's the boss. See, it's an indirect. It's like 1 plus 2 plus 3 is 6.
I think
number
that's
6. Karthik, you see that?
I don't know.
I don't want to comment on that.
Ray always says he'd rather have all the hair.
It took me quite a while to get my hair back, so thank you.
So, I mean, with everybody back home, I mean, all the fun is happening. But, you know, we're right now, Karthik is putting on the cheater for us to advance this little catheter through. Hold on, I'm going to have to walk it out for you to withdraw. So I'm going to put this down distal.
All I know
through
is
that
from now
lesion.
onwards, any hair discussion, I'm out
Very
of there.
barely. So Karthik, I mean, in terms of how are you going to deal with this common femoral now? Now you got another challenge because now you have internal iliac. I think we just do a
So
plain
we can't even
POBA.
extend. Yeah, that's what I would do.
I think we just do a plain POBA here.
Take a 6 or
Right,
do a plain
and then I'm just gonna walk this back.
Go more down.
Why?
Why?
Why can't we not do a DCB?
Why?
We
We're
can
all
do
the
a
way down.
DCB right there.
DCB won't go.
Wires all the way
length
down?
No,
the
DCB
length
has
will
a
not
shaft
reach.
of 150.
Wires all the way down?
Go a little bit more.
No, that's all it can go. It's resistance. Wires all the way
Okay, I
down.
think you're one of the
baby chair.
branches.
You
You're
can
good.
easily go big.
Wires down, dude. You're in the profunda. So you don't want to push that any further. You're pushing.
Yeah. Give a metacross 6060.
So the last thing you want to do here is perf the profunda, guys. So it's very important here to be careful not to go further than you need to with this wire. This wire is a stiff wire. It's got a J-tip, yes, but the profunda has many branches that can easily burst, and now you have no access. So now what we're going to do is we're going to go with a 6-0 metacross and then decide on our stent. So let's do a roadmap here, please. Ready?
Yeah, go ahead.
Mm-hmm.
60. Yeah. 200?
Oh, you don't know. You don't need 200.
Yeah, you have
No,
150.
just
what's the
60.
focal?
60.
No, I think we got 2 focal lesions.
Yeah, 60.
You want to do 60? 60 is fine. We can inflate it twice.
There's one
Yeah,
lesion
one.
down here
Well,
also
we'll do
to
one here and one there, right?
Flow.
Let's come toward me.
Yeah.
Go, Ario.
Yeah.
Let's do it. Let's do a DSA picture now.
I mean, in this case, if you are worried about the glide wire being in the profunda, you can exchange it for a supracore, because the metacross is a rapid exchange, so you will have enough length to exchange the balloons.
I don't think that should be a problem, Sardar, because it's a baby J, so it really doesn't perf much. It's actually a very good safer wire to have. The reason why you want to have this wire is because it's a 400 wire. So if something happens, you at least have an access of the wire, so you can rapidly exchange it to an exchange length catheter. If you have supracore, then you suddenly lose your access wire and everything. So this is a good wire to do the iliacs on. I mean, that's why they got this wire down, so that you can always have access if you have issue with like perforations.
The nice thing about these balloons are obviously, you know, their rapid exchange, which really is going to help us.
So the stents also are rapid exchange.
The stents are also a rapid exchange, which is very elegant and nice. So we're going to just go down into this.
Well, I guess one of the treatment strategies which you could do is just like we do in large bore accesses when you do impella, is if you have a lesion of the iliac, is you balloon the iliac with your metacross, then you can drive your sheath over the balloon shaft, bring it down to the distal external iliac, and then you can do a DCB of the common femoral.
True.
So that way you can get both your DCB down to the common femoral and do your stenting on your way out.
Well, listen, I'm kind of waiting because I don't know how my flow is going to be after I do all this. Once I do all this, then I'm going to decide whether I want to go after the my distal lesion, and then take it from there. So here, what's nominal, guys?
8.
Okay, that's 8 atmospheres here. So we're just going to leave it up at 8.
So that's a 606. What size is it? 6060?
6060.
6060. We're just undersizing it a little bit just to crack the lesions down. So now I'm going to walk it back and do the proximal. And, you know, listen, it's now also not wrong to stage this if you need to, right? I mean, if you need to stage it, we can always stage it. That's not an issue. I mean, I just think that at this stage, we felt like we could do it because of the radial axis. That one's really, really tight. As you can see, it'll go really slow. So, you know, we really got to be careful because of the calcium. You know, we wanted to do shockwave, but of course the balloon size would be very prohibitive. So, you know, you really have to think about all the things, you know, you're doing before you start. You know, right now, I'd go up again. So I don't know what atmospheres you were up to.
Pull back. 8.
8. So he was up to 8 atmospheres. So just going to pull back slightly and go up again one more time. So I just want to make sure.
These are all the challenges with radial access. I mean, it sounds always very intriguing to do most of your peripherals from radial access, but then you end up quietly limited with your equipment, with your devices, and certainly also in the iliacs with your bailout options. Right?
I'm not really convinced if that's expanded. Does that look expanded to you guys?
Yeah.
Go up again.
Just because there's calcium
not
there.
That much, I think. Yeah.
Let's just go to 8 atmospheres again. Really expand it. Try to expand it. There's a lot of shadowing, as Dr. Guja is saying.
Yeah, the calcification right there.
Yeah, just leave it up at 8. I agree. Down?
Just today, yeah, it looks fine. Okay. It looks expanded.
No, now it looks expanded.
Pressure went
Not just me. It's my hands.
No, pressure went down.
Little die, guys?
Get a VBX ready.
Oh, it's going to be fine.
Big perfect.
Well, you can't see anything.
No.
Take it out.
No, you're fine. This flow. There's no perf here.
What size? 7.0 short or 6.0 short.
It's fine.
You'll be okay.
7.0. Yeah, no, it's not.
Put a DSA. Take a
DSA? No, pressure's beautiful. No, you don't need the VBX.
Just keep
DSA?
it in, no? 24.
Okay, we're fine. All right, good. Nothing good, nothing bad. So now we need to do our stenting.
Huh? Common iliac is involved too, right?
Not really.
I think so.
Show me the DSA shot of the.
Oh, there are 2 lesions. One, if you want to call it common,
no, nothing.
No, you hit her. That's why she moved. Yeah, so it's okay. Huh? Yep, that's perfect. Show me the first shot. Dr. Guja is feeling the common iliac is involved. I didn't see it in the iliac shot, so we'll do an iliac angiogram, which we did earlier. Go to the first picture. So that's why it's always important to get a diagnostic picture of the iliac before you start. Go to the first angiogram, guys, that we did. The very first angiogram.
Yep, go.
I think you should just go to the scenes and then go to the first angiogram. Might be a lot easier. So what we're going to do is we're going to go to the scenes, go to the first picture right there, that number 3.
Two,
Yep, that's the one. Yeah, that's the one. And now you'll take a picture and you'll be able to see what's happening. So yeah, the common iliac is diseased but not really involved. See that? So I'm not touching that. You know, there is. So now I agree with Justin. Maybe we go with a longer stent, starting from the distal common iliac. The other thing also we could do is now take a full aortogram with a pigtail to really be able to see. So the problem with doing this at this stage is you're probably going to lose your wire position. So that's also an issue, right? So what is this now?
1 second.
Oh, our stent is stuck here.
Yeah.
Our balloons. So, you know, that's another thing with these turbo wires. You got to obviously keep them wet. So can I have a forceps? So this is part of the, I guess we're going to try this. Hopefully we don't lose it. We'll see. Go ahead. Good. Oh, you got to wet it.
I did.
You got to wet the, yeah.
Keep wetting it at the same, yeah.
Nah, it's not going to come. No, yep, we're going to have to lose the wire position, unfortunately.
Wait, hold it. Okay. 1 second, it's just stuck on it.
There it goes.
I got it.
Why just wipe it down now?
Yeah, I did.
Just wipe it at the same time. We did.
Mm-hmm. It's just, I think it's because of the calcium and everything.
Oh, no, I don't think this is calcium.
No, it's all about, this is the external part of the wire.
Got it.
You just have to take it out.
Yeah, it just wasn't wet.
Yeah.
All right, now let's go ahead and get me that. Let's take another really good picture. What's our flow rate? Okay, ready? All right, ready to. Let me see where my sheet is.
It's up there.
Okay, it's in a good position. All right, ready, guys? Okay, now we can see it.
So we take a.
All right.
8 or a 9 long stent.
Well, I think the longest we have is 8, so we're going to get an 8080, right? I would go with 100. Give me an 8000.
Yeah.
8000. What is it called? Misago stent here.
Misago stent.
So we're going to start from 26 or 27 and come up as long as we can. I think 26 is good or 27 is good. So 100. So again, with iliacs, obviously you don't need any extra oomph. I mean, our patencies with these iliac stents are great. The Misago study was done. What was your trial called again? Can you guys talk a little bit about the Misago trial data and the registry data?
Osprey.
Yep, the Osprey. Do you have that in your lecture?
Yeah.
Hold on. So let's cut out to Raman.
All right. So we spoke a lot about what the next several slides.
So Roman, you could shift over to Ray, we'll load it up. Okay.
So we spoke a lot about this, but I guess we'll briefly, just for the educational purposes, go over this again. You know, as far as for this particular case, what the best approach for the axis would be. Whether Transradial is obviously the one that we had gone. The questions were also whether we would approach this from a direct SFA axis. I don't believe we did earlier show the SFA and the mid thigh, which could have been an option should we have had to, but it did seem that there was a moderate to severe disease over there as well. Transpedal also being another option. The main things to consider about the pros of each of these for the transradial axis is the issue that there is much less vascular and bleeding complications, and the patients are also able to ambulate earlier as well, and they just generally feel much more comfortable. It also does allow you to it requires you to have a little bit more of a strict selection process to make sure that you're able to do your entire intervention on the patient with a single access. Transpedally, similar pro of not having the same vascular and bleeding complications. The direct superficial femoral access, with direct SFA access, you're fortunate in the fact that all of your devices that you have for your regular up and over, CFA access, you're able to use that for your SFA access. So it's quite convenient. All the devices the length will not be an issue at all that you do see here with your transradial approach. The major negative that we've also already discussed at length with the transradial is that the devices are just not entirely present, for all the appropriate shaft lengths and, the sheath sizes to give you the appropriate bailout options you may need for aortoiliac disease, as well as the DCB. The DCB options are also somewhat limited. That being said, the data and indications for aortoiliac use of DCBs is also not present anyway. And again, as we saw even in this case, the issue of radial spasm is also something that you'll also have to work with. Transpedally, another con is, a lot of these patients with severe PAD will also have pretty significantly diseased peripheral arterial disease all the way into the pedal vasculature. So there's always a chance that you can cause even further injury there. And another thing that we also teach here a lot, transpedal axis is not very commonly used as a primary axis, but rather as a secondary approach to help you externalize a wire and facilitate lesion crossing. And the cons about direct SFA axis is mainly the fact that it's not an easy compressible vessel. So axis site complications are not rare. Next slide, please. We spoke about this, a lot of these spasms, and one of the main issues is just the lengths that we see, as far as what the shaft lengths available are for the aortic disease as well as the SFA lesions as well. So the length to reach the distal SFA in the average person will probably be about 150, 160 centimeters from the left radial artery. Next slide. So this is the sheath that we are using today. The R2P destination slender comes in 6 French size and 119 and 149. We're here today using a 119 centimeter, very hydrophilic, so it allows for a very smooth delivery, but still you still have to navigate the same radial artery spasm that you may have to worry about. So this is the one that we use, and we were speaking earlier with Justin whether or not they're going to be working on a 6-7 destination slender sheath. They're also coming out with shorter sheaths as well to work on some clavien artery interventions from the radial axis as well. Next slide. For as far as the PTA balloons, again, the issue always comes back to just what shaft lengths available do we have and what will fit through the sheath that we have in the radial artery. As you see, largely the majority of the balloons we have are in the 130 to 150 range. A few here and there are in the 170 to 200 range. The Metacross is one of the Terumo balloons that is probably one of the longest shaft lengths available. Next slide. So yeah, this is again the PTA Metacross balloon, the rapid exchange system that we use in this case. It comes from 3 to 8 millimeters in diameter, up to 200 millimeters in length. And again, this is a rapid exchange balloon that Terumo makes. That is the longest currently available shaft length PTA balloon. Used well from the radial axis. Next slide. As far as the stenting options here, one of the main problems here is, again, the same shaft length. We see that the longest shaft length available that we have is the Express SD from Boston Scientific. It's a balloon expandable, but then the issue still just becomes that, as far as where you're going to be needing to use the balloon expandable stents. So if you have to do aortic-iliac stenting where you need to have a balloon expandable, perhaps in a certain patient's selection, you may be able to use these stents appropriately if you have very proximal osteal disease that you have to really nail appropriately, because the 120, 135 shaft lengths may be sufficient to give you what you need. Next slide.
I know, I'm being careful.
Self-expanding stents, again, same concept. We see that a lot of these are, again, still the 135, 120 or so.
It can always come back.
We see that as far as the drug-eluting stents, the Zilver and we don't have that here, but they're all still been in the 125 to 130 range. So we see that we're still largely limited by the shaft length. Next slide. As far as the Misago, which is the newest one by the Terumo group, also comes in the 6 French compatibility and also has a 200 centimeter shaft length. This stent was observed in 3-year data in the Osprey study. It followed about 275 patients over the course of 3 years. That showed quite impressive results and largely driven success. There was a single arm study based off clinically driven target lesion revascularization. That was about 78% at 3 months. That was persistent at 36 months at about 75%, with improvements in Rutherford grade class and other subjective questionnaires of patient sensations. So it was a 3-year study, single arm, multi-center, about 278 patients. So they followed them and saw that at 3 months and 3 years, the clinically driven targeted lesion revascularization was about 78 and 75%.
Okay.
So it's
but what was the primary patency? Down? Wasn't reported? They didn't look at primary patency? Okay.
But they saw that the stent fracture rate was quite low.
Okay.
Only about I think 4 out of all the patients had that.
Let's see how this looks then.
And again, improvement in all the other qualitative measures. Next slide. Lastly, the last thing to talk about would be just what about the DCBs? We were lucky enough to move one down to the CFA with using a 130 centimeter shaft length of an impact. But again, this just kind of works out well for us because this is quite a short lady, and we were able to just barely maneuver our devices distally enough to reach what we had to. So, and as for right now, in the particular patient population, perhaps a DCB will be successful.
I'm happy with that.
CFA lesion, or also SFA, given you have the management of the radial artery spasm, and you have a patient selection of people who are not very tall, and your devices can simply just reach the places where they have to go. That's it.
Awesome, Raman. All right, so let's see where PK is up to.
Yeah, so go see minus Karthik. So what we decided to do was we deployed the stent, and then once we deployed the stent, we took a picture, and minus Karthik one more. And then you can see the stent's already deployed. It's, again, a wonderful system, this Misago system. Easily deployed. We used an 80 by 100. We haven't post-dilated it because we felt it looked really good at this stage. And then you can see distal to the stent, there's a significant step down. So we took a zoomed up picture of that, which clearly showed a common femoral lesion at the level of. So here we know we're not going to use a DCB because I really don't want to drag a sheet through that freshly laid stent. So I decided, with Karthik and I talked about it and decided to go with this 5040 balloon from Terumo. And what's the name of the balloon again? Metacross balloon. And then this is with a 5040 Metacross balloon. We have resolution of the stenosis, however, no dissection, which is really what we wanted to achieve. So we've got good flow into the profunda. Now, before I do anything for the SFA, what I want to do is I want to look at the distal leg and to see the filling. So low mag and show me the leg. So what I'm going to do now is take my pigtail down into the stent and take a picture, because I want to take a selective left leg angiogram to decide what I'm going to need to do. So what are the options here? The options are, well, now we can get direct femoral access, SFA access, or we can go ahead and get a pedal access and revascularize the SFA. But I don't think we're going to do that live. Obviously, it's 1 hour, but I think that we may either do it now or we may see how she does and stage her depending on the flow. I also have Elizabeth and her magic fingers. She's going to try to get a pulse for us. Our young lady here didn't have a pulse earlier on, so if we have some sort of good pulse, at least a Doppler pulse, which we did not have before, I think we've definitely experienced this. But let me take a picture first, and then I'll tell you.
I think it's a good strategy to think about even staging as well. You already fixed the right side. The left side, you're fixing the inflow, especially the profunda going in, and the profunda looks robust. So if the profunda supply is there to the lower limb, I think Sardar, we should be able to achieve some kind of stability, and then probably bring her back and fix the CFA into the SFA CTO as well.
Absolutely.
So I think it would not be wrong to, I guess, just hold on to the further strategy right now, see how she does, and then probably have a definite stage procedure.
So yeah, we're not going to be able to get this all the way in. Let me see where it is. It's probably just at the iliac, not even.
Yeah, because it's a 135. So
yeah, that's good enough. I think we can try to. Do we have a longer pigtail? No. Okay. So then I may try to just expand, push in my guide here a little bit.
I got it. Go ahead.
You have to shape your pigtail.
Actually, just leave it. Yeah, we're just going to leave it here and take a picture. Yep.
It's fine. It's okay. You can.
Yeah, we're right there, which is fine.
It's a side hole, anyways.
Yep, it's a side hole, so it should be okay. Like Karthik said, with injections. Come forward, guys.
Well, sometimes you have to do, you can use an angled word tip catheter as well, take it down, and because it's a bigger size lumen, you can inject through it, selectively inject into your iliac as well. So that's one of the other strategies you could probably use as well.
I think the only thing we can really use rather than an angled word tip is their Terumo catheter.
Yeah, any long catheter.
Which is 150, which will clearly take us to the common femoral. But
Right.
I just figure we'll do a iliac shot here from here. So we're going to go ahead and inject and see the filling. Now that is a lot better.
Oh, it's beautiful.
Yep. So now we're going to see below. Sorry. Thank you, Karthik.
Put a leg in.
Yeah, well, we had to rotate her because we were thinking about a pedal access, right? So, inject, guys. So you saw the flow in the foot was quite poor before. So now it's incredibly robust.
Wow.
Really two-vessel runoff to the foot.
You can get an
right?
AT access and do it.
Right. And then we can do the foot shot. Again, she's got the ulcer. And the ulcer is where, gentlemen and ladies?
The first toe.
The left first toe.
The first toe. So it's anterior tibial distribution. Is it in the plantar aspect or the...
It's like all the way around.
It's all the way around. Okay, inject.
Where do you go? AT is coming.
Yeah, it's going all the way down
Yes,
to the
AT
base.
is there. Yeah, the AT.
Well, yeah, but no, everything is being filled. But I'm just saying that now we just need to discuss what we want to do here.
She's heart failure. We gave dye. So I think.
Huh?
She's,
I think I would probably
she has
would
heart
want
failure.
to
We gave
stage
dye.
it.
Probably
Inject.
stop it. Bring her back.
Yeah.
We can do
I
it.
think that'll be a smart
We can-
strategy. Improving the influence, seeing how she responds, and then having stage intervention of the SFA will be.
That's really
all the
good
way
flow.
right
Yeah, I think you're right. I think that might not be a bad idea. So I think at this stage, I mean, let's see whether Liz gets a pulse. Liz, can you do the honors?
there.
Okay, Ray, can we get an ACT, buddy?
Yeah.
Can we move this Damien down? Okay, good. Uh-huh. You have to undo this. So we're just going to go underneath and get a pulse. So yeah, I think at this stage, I mean, we've done a good job in terms of revascularizing. We have fantastic flow down to the foot. Even if I can get a monophasic pulse at this stage or a biphasic pulse at this stage, we've given about 180 cc's of dye. She has a history of diastolic heart failure. I think we're gonna end up stopping here and go ahead and decide at a later date how to do it. One other option that we did not talk about is the possibility of a bypass with a common femoral endarterectomy as well, because she has wonderful tibial vessels. Question is, she has a bypass on the other side, and this is the question here. So Liz is looking for the pulse here.
I think that's one of the good strategies, always to discuss with the patient what are the bypass options, the feasibility, the patient's response, and of course the long-term outcomes. So in this case, you're right. Bypass is definitely one of those good options, especially the fem-pop. You improve the inflow anyways. So now if you're unsuccessful or the patient deems good candidate for a bypass, it's definitely a very good viable option in her case, knowing that the right side is doing very well as of now. So, but again, the availability of the veins and other technical issues with bypass will come into the question when we start discussing. So venous versus PTFE versus mix. So I think that's one of the strategies. I'm sure you'll have some PT pulse as well.
Well, with that, we need to find the pulse. And there are times when I have to use my magic.
You want to go a little bit
because the pulses are difficult to find, and right now we're having a tough time finding it. With that flow, I'm shocked. But we're gonna have to see why we can't find it, which is surprising.
But I'm sure
to me.
we'll be able to.
Well, it's one of those things. I think for the audience, I mean, you want to achieve your goal before you get her off the table. Right. I mean, we had very significant inflow disease, and with significant inflow disease, you definitely want to be able to find the pulse. If you can't find the pulse, then that's an issue. And maybe then you have to think about fixing the outflow. If Karthik is also having trouble finding it, then we might have to go for it. So I think at this stage, anyway, we're out of satellite time anyway. So what we're going to do is we're going to go ahead and talk about this, and we'll upload this if we decide to do it as part of the case. But if we are able to find a good pulse, which I don't know why we're not, I'm going to go ahead and either get access in the tibial, go up and fix the SFA, or what we're going to do is we're going to go ahead and get a direct SFA access and fix it. So with that, we're going to sign off with a nice case demonstration of iliac intervention from the tibial, from the radial artery, using all sorts of devices, including obviously the Terumo portfolio of R2P devices. Obviously, Terumo has it, Medtronic has it. There's a few more, but Terumo has the most extensive portfolio available, including wires and sheets, as well as other things. So what we're going to do now is we're probably going to go down and check a pressure gradient in the iliac to make sure that we've gotten all the lesions, because Karthik was suspecting a common iliac lesion, and he might be right. So we're going to go and take a look and take it from there. So with that, I want to thank you guys for joining in. Happy Thanksgiving. We'll see you in December.
All right. Thank you, BK. A great demonstration, a great discussion of alternate access, especially the radial intervention of multi-vessel iliacs. Thank you for joining us. You can watch this case and our previous cases on our website, ccclivecases.org, under the peripheral arterial section. For next month, we'll see you on December 16th, which is a week ahead, which is the third Wednesday of the month, because it being a Christmas the following week. So December 16th, 8 o'clock Eastern Standard Time from Mount Sinai. Till then, from me and Sardar, have a happy Thanksgiving. Please be safe, and we'll see you next month. Thank you.
Happy Thanksgiving.